Hello, you are watching a recording of IAPMD's Journal Club. We're excited to bring to you this new platform to discuss the latest research on premenstrual disorders. Everyone is invited, whether you have PMDD or PME, are a supportive partner, researcher, or healthcare provider. We aim to foster a rich discussion from diverse perspectives. Today's session discusses a recent paper titled The Bidirectional Association Between Premenstrual Disorders and Perinatal Depression. If you would like to attend a live Journal Club session, please follow us on Instagram at IAPMD_global.
I'm very excited to welcome you all to our Journal Club session. So today is very special because we're bringing together members of both the professional and patient communities to talk about the latest research in premenstrual disorders. So this is a mixed group. Okay, so we've got 12% researchers, 12% students, 15% healthcare professionals, 48% patients with lived experience, and then 12% other. So really a great mix, and we're hoping that we can all, in the discussion of the article, we can all sort of share experiences and learn from each other. So to those of you who are new to IAPMD, so the International Association for Premenstrual Disorders, we are an international nonprofit providing information, support, and resources for anyone impacted by premenstrual disorders. And I just want to take this opportunity to put in a plug for our new ebook, which is available for purchase on the IAPMD website. So this book is the result of years and years of hard work by the whole IAPMD team. And it really covers everything you need to know about PMDD and its treatment. It really is a fantastic book. Everything all in one place, very well researched, really evidence-based information. So have a look at that if you're interested. So in 2021, we launched the IAPMD professional community with the mission of bringing together professionals to advance education, accelerate quality research, and create a global network of experts. So for those of you who are part of the professional community, as part of your membership, you gain access to regular webinars provided by expert speakers, clinical discussion groups, and other networking opportunities. And now the latest addition to the list of events included in your professional membership are journal club sessions, such as today's. So in case you aren't familiar, journal clubs are quite common in research settings in academia and universities. It basically involves researchers coming together to discuss a scientific paper. So they discuss the methods of the study used, the strengths and weaknesses, the implications for practice and future research. So one person typically provides a summary of the article and then leads a discussion afterwards. So today we'll be discussing a paper that was very recently published in a journal called PLOS Medicine. But as we were planning this session for the professional community, we were thinking that this paper and this topic would also be of interest to the patient community as well. So we decided to open up this journal club session to patients and to be mindful to present the paper in a way that would be understandable to the entire audience. So today we have Jordan Barone, who is an MD PhD student at the University of Illinois, Chicago, and she's volunteered to be the presenter today. So I'm going to stop sharing and Jordan will take it away.
Hi, thank you so much for having me, for kind of letting me spearhead our first journal club discussion. Let me share my screen and get some slides going. So just really briefly, I'm an MD PhD student. I've finished the PhD portion of my research. I, for 4 years, was working under Dr. Tori Eisenlower-Mall, studying kind of biological biomarkers of menstrual cycle mood disorders or premenstrual exacerbation, and looking at kind of why some people are sensitive to the menstrual cycle. But part of being in this field is that you kind of get to read everything, right? So I want to be really clear that this is not my specific research area. This is not a paper I have any connection to, but I've been involved in so many journal clubs over my graduate training that now that I've finished my PhD training and I've moved on to my MD training, so I'm in my 7th of 8 years of training for both my MD and PhD degrees. This is kind of a phenomenal way for me to get to stay involved in the research and in the communities that I had been working in, while still kind of not being fully in it full time anymore. So with that all said, I'll try to stick to about 20 minutes. And I'll let you know, I'll try to be really clear about when I'm kind of like inserting my own thoughts and when I'm trying to be as objective as like, this is what the paper said. And hopefully then that'll lead into some good discussion after. So as you all know, this paper was titled The Bidirectional Association Between Premenstrual Disorders and Perinatal Depression. And this is a nationwide register-based study from Sweden. I'm going to start with the abstract. That's how I always start with reading papers. I'm not going to actually read it all to you, but first thing was the background. Okay, if we skim this, their aim was to investigate the bidirectional association between premenstrual disorders, which they use PMD, and perinatal depression. Methods and findings, we're super not going to read through all this, and I had to cut a lot out just to fit it here. But really briefly, like, okay, so we're looking at a bunch of pregnancies in the Swedish Medical Birth Registry. And they found that PMDs were associated with a higher risk of perinatal depression and vice versa. Okay, we can take that. And the conclusion is that a history of PMDDs can inform PND susceptibility and vice versa, lending support to a possible shared etiology. So I'm going to kind of chime in a bit with like how I get through this paper, because I know we're about half patients, non-healthcare research professionals in this group. So I want to be conscious of that. So this is kind of how I would start. Just go through the abstract, what jumps out at me. So today we're going to talk, I'm going to give you like a 2-minute crash course and kind of things that I always keep my eyes out for when I'm reading literature on PMDs. I'll talk about the background, kind of really stick to what the paper described as the background. So why study these together? What do we know about them? We'll run through their methods and their results, and then we'll talk about the conclusions that are in the paper, and then I'll zoom out and kind of add our own conclusions, things that maybe from an outside perspective you can think of, and then I'll suggest some discussion questions for our breakout groups. So when I'm reading literature in the premenstrual disorders field, a couple things I always check first, like looking at the publication itself. Where was it published? Was it in a peer-reviewed journal? Is it in more of a news magazine? When was it published? Is it recent? Was it peer-reviewed? How did they diagnose PMDs? A lot of you are going to be really familiar with this process. That the only way to truly diagnose PMDs is with daily tracking. So this is just an example of part of the DRSP. I always like to know what they did about what they included for hormones. Some studies will track hormones daily or with blood draws or with urine strips. Some studies won't use hormones. And when I'm thinking about hormones, I'm also thinking about hormonal medications. So not just did the study track hormones across the menstrual cycle that we're interested in, that we know are relevant to PMDs, but did they include people on any hormonal contraceptives or on any hormonal medications, and how might that impact the work? Looking at either the menstrual cycle or the PMD itself, was that used as a predictor in the study or an outcome? And what that means is, are we asking, does the menstrual cycle impact something else? Does the menstrual cycle cause a change in, a common one, like change in depression day to day? Or is it an outcome? How does some risk factor impact your likelihood of having PMDD? That type of thing. And then this is really more for myself, like a little check my own bias and expectations. What conclusion can I not draw? Because I'm gonna want to take the paper farther. I'm gonna want to say something broader than what I really can, because you always want to keep moving things forward. So I always like to give myself a little limit at the top. Like, what is this not saying? Keep myself in this space. So for our paper, our Yang 2024 paper, I'm just gonna run through my little check boxes. This is really recent, May of 24. It was published in a peer-reviewed journal called PLOS Medicine. The impact factor is relatively high, which just means that there's a lot of people cite this journal. And this is an interesting one. If you go to the website, you can actually download the entire peer review history. So all the comments that they got from reviewers and then all their feedback. So you can really see how this paper became what it was. How did they diagnose PMDs? This is an interesting one. We'll talk about this later. They assumed that every clinician out there who checked a box for someone for someone having PMDs was using the accepted Swedish guidelines, which means 2 months of daily ratings. And they also used prescriptions as a proxy for diagnosis. So if somebody was prescribed an antidepressant or an oral contraceptive with the indication of a premenstrual disorder, they gave them the diagnosis. We can talk about that as well. I know that probably many of you in current clinical practice are like, yeah, that's not usually how it works day to day. We can't assume that that's always what's happening. There wasn't any hormone tracking in this study, and they mentioned hormonal contraceptives only as that diagnostic factor. So they only talked about it in the sense where if someone was prescribed OCPs for a presumed diagnosis of PMDD, then that's how we know that they have them. But there's no like controlling for people with contraception. This is an interesting one. PMDs are both used as a predictor and an outcome. So we're asking, do PMDs predict perinatal depression? But also, does perinatal depression predict PMDs? And then I know that I'm going to want to say, okay, these must have a shared etiology because they're related. And that is not a conclusion I can draw from this paper. So that's immediately what I'm like putting my brakes on for myself, that I have no reason to know why these two might be linked if the paper shows that they are, which we know that they do. So the background in this paper, I'm going to be really brief. I'm just going to quickly give a few definitions that they give us. So they define perinatal depression as depressive symptoms during pregnancy and up to 12 months postpartum. And they cite the prevalence as 11% of mothers globally. And premenstrual disorders, they define as somatic and/or psychological symptoms that recur in the luteal phase, with a prevalence of 20 to 30% of reproductive age females with PMS, kind of the milder form of PMDs, and then 5.5 to 8% with PMDD as the prevalence. And they don't actually use this word in the background of the text. They describe it as severe symptomology, but as IAPMD, we know that is kind of the accepted prevalence of PMDD. So the reason for this link is that both these groups of disorders are characterized by psychological symptoms that respond to hormone fluctuations. Both can cause distress, they can cause impairment in people's day-to-day lives, and they can even lead to suicidal thoughts and behaviors. And because of this overlap, it's been hypothesized for decades now that both sets of disorders are adverse neurobiological responses or adverse brain reactions to normal fluctuations in estrogen, progesterone, and the neuroactive metabolites that act in the brain, which means that there could be this shared mechanism. Maybe it's similar causes that lead to someone having PND or PMDs. I'm going to try to say the full words when I can. And then there have been a couple of reviews. There's been a lot of research on this already. And I just pulled up 2 systematic reviews that look at all the data that's out there that do show an increased odds of postpartum depression in people who self-report PMS before pregnancy. And what the paper argues is that the studies to date are all retrospective. So it's asking somebody after they've had their baby, did you used to have PMS symptoms as the relationship? And then there is a selection bias because these are people who volunteered to participate in a study, which is not the case in this paper we're reviewing today, which is just looking at all birth records in Sweden. A little bit more about what we know about the link between these two. So kind of one leading possible mechanism is the idea of neuroactive steroid sensitivity, or as I said on the last slide, a brain sensitivity to these steroids that come from estrogen and progesterone that act on the brain. Tons of research has shown that in both perinatal disorders and in premenstrual disorders, there's normal hormone levels across the whole cycle or across pregnancy. This isn't like a hormone imbalance disorder. And there's normal hormone changes that people are rising and falling as the healthy cycle or pregnancy is supposed to, but that there's something that kind of triggers a sensitivity to change. So that's a big overlap between these two. They also overlap in how they present, where there's spectrums of severity. People talk colloquially about PMS just being like an experience that a lot of individuals can have with their menstrual cycle, all the way up to the severe debilitating form of PMDD. And people use the term colloquially baby blues for, a few days or a more mild depressive symptoms after pregnancy that can develop all the way into postpartum depression. And my point here is that neither of these are disorders where, you check a box and you have it or you don't. There's truly degrees of sensitivity or degrees of severity. And then finally, I'll just mention that because of this, there are a lot of overlapping treatment targets for both of these families of disorders. So For postpartum depression, brexanolone is an approved neuroactive steroid-based treatment. There's a lot of steroid-based treatments that are currently under research for PMDD. There's a lot of interest then in like neurotransmitter systems like GABAergic transmission, serotonergic transmission, and then both can be treated with cognitive behavioral therapy as well. So a lot of background there. Let's get into this paper a little bit more specifically now. So for their methods, and to be clear, I'm going to be pretty surface level when it gets to their methods, and we can kind of take questions later as it goes. There's obviously a lot more in the paper, and they have a pretty substantial supplement as well. So they collected data from 1.8 million pregnancies in the Swedish National Birth Register. That's a huge sample. Singleton just means people pregnant with one baby. They excluded anyone who had like twins or triplets. And these are all objectively collected from these registries that in Sweden, rather than what I talked about earlier, which is people who in some studies kind of self-select or volunteer for a research study. The way that they diagnosed PMDs was using in the medical charts in the registries, the ICD, or the International Classification of Disorders code for premenstrual tension syndrome. So some medical provider had to have selected this code for the patient for them to have met criteria for PMD. And I wanted to put something in quotes here. According to Swedish guidelines, prospective daily symptom ratings for at least 2 consecutive menstrual cycles are required. So the assumption is that these are all diagnosed with prospective daily ratings. We can talk later about assumptions and whether or not that can always be trusted or not, but that is kind of what they're relying on. And then they also counted people in their PMD diagnosis group if they were prescribed an antidepressant or an oral contraceptive with the indication listed as PMD in free text. So they used a medication register, so a different one, to find out who's taking what prescriptions. And if someone was prescribed antidepressants or prescribed an oral contraceptive, which are both first and second line treatments for PMDs, and if they said in the free text for PMDD or for severe PMS, then that would count as a diagnosis. Pretty similar for the perinatal depression diagnosis. This time they used more ICD codes. So if someone was kind of checked off as a depressive episode, a depression parentheses unspecified, that's just how medical coding works, or mental and behavioral disorders associated with the puerperium, not elsewhere classified. So any of these codes that occurred within 6 months postpartum, they would count as a perinatal depression diagnosis. And then similarly, if someone was on the registry as having been prescribed an antidepressant within 6 months postpartum, they counted that as well as someone who met criteria for a PMD. For their analyses, there's really just 2 big questions in this study. So I'm going to kind of pull through a lot of the weeds and just say there's 2 main things that they asked. The first was, does having premenstrual disorders affect your risk of having subsequent PMDs? So let's say, if you have PMDD and you don't have any, if you've never been pregnant, what is the risk that you would have a perinatal depressive episode with your pregnancy? The SAT they reported is odds ratio. And then the same exact thing, opposite direction. Oh my gosh, I wrote the same thing twice. This was me struggling with acronyms. The next one was in someone who had PND, perinatal depression. I am so sorry. What was their risk of later on, years later, developing a premenstrual disorder? They reported a hazard ratio. And I am not an epidemiologist. I gave my intro at the beginning that this is not my background. I do have a good friend who's an epidemiologist. So I did run this by her this week just to double check that I was getting the language right. And because of the way they designed their studies, for today, we're just going to call these the same thing. The way that they pulled out the time component of each study allows them to say that whether they're looking at the odds ratio or the hazard ratio, the question that they're answering is, what is the risk that a person in X group, so a person with a PMD, will get the Y outcome, will get the perinatal depression, and vice versa. In real day-to-day, like if you're doing this research, an odds ratio is more of like a moment in time thing that you can't predict risk over time. But because of, again, how they followed people and having nested their design, this does work for today. We'll also talk a little bit about covariates. So they covariate country of birth, educational level, if they lived with a partner, where in Sweden they lived. And then they also did an additional model that added more covariates with interaction terms, which asks the question, do our findings depend on any of these other variables? And for those, they used smoking, BMI, psychiatric history, or parity, or how many pregnancies the person has. If you're not familiar with the term covariates, by the way, it just means that you're controlling for another variable. You're saying, okay, does our finding still hold over and above the impact of this other variable on our outcome? And then they did some interesting sensitivity analyses at the end that I was really excited to see, where they repeated all these analyses, but they only used clinician diagnoses. So they didn't use that you were prescribed an antidepressant as a proxy for diagnosis. And then they also removed people who had pregnancy complications. So like risks to the fetus at birth, pregnancy, like hypertension disorders. There's a lot of things that could lead to over and above, like a huge air quotes here, normal healthy pregnancy, that could lead to a lot of additional stressors in that period. So the results are going to be kind of simple. Do premenstrual disorders increase risk for subsequent perinatal depression? Does perinatal depression increase your risk of having a subsequent premenstrual disorder? And then those additional analyses I just mentioned. And the answer to both of those questions is yes. So I'm just gonna we already read the abstract, right? So the answer is yes. This table is a little bit dense to get through. So I circled what I think kind of is the main point, which is that overall, people with premenstrual disorders were 4.98, or about 5 times as likely to have subsequent perinatal depression than people without. All of these analyses below are just ways of stratifying the analysis, or saying, well, does it really only predict first trimester perinatal depression, or does it matter when after birth the depression was diagnosed? But you can see all these numbers are pretty similar. So the main finding here is that people with premenstrual disorders were more likely to develop perinatal depression with a future pregnancy. Very similar in the other direction. So now in this study, they looked at people who had perinatal depression. They followed them for actually years, about, I think the average was like 6 or 7 years, to identify if in their chart they ended up developing a premenstrual disorder diagnosis. And same idea here, these people were about, people with a history of perinatal depression were about twice as likely. And again, that holds true. This is all kind of right around 2, no matter what they controlled for or how they broke up when the diagnosis of the PND occurred, since perinatal depression can be postpartum, it can be early in pregnancy, it can be the whole time, etc. And then this is something that I think is very specifically interesting, probably to a lot of the researchers in the group today. We talk a lot about comorbidities with other psychiatric disorders, and how it's a very kind of complex interplay between many symptoms, and it's hard to just put people in individual diagnostic boxes all the time. These were analyses that showed that the patients who did not have any other psychiatric diagnoses were actually more likely to show that link between perinatal depression and premenstrual disorders, and the other direction as well. That surprised me. That was something that I didn't expect out of reading the abstract. So I always like to kind of draw an extra beat of attention to something that I think is different than what I would expect. I would have expected that people with more, that are more prone to more psychiatric diagnoses are also more prone to then develop future ones that are linked together. But it looks like this link between premenstrual disorders and perinatal depression holds very strongly over and above prior depression history that isn't hormone linked. And then the final thing I want to talk about for their results were those initial analyses. And this, if you read the paper that we sent out via email, you actually have to go to the main web page and pull this. It's called supplementary information from the journal itself. It's only available online. But this is where they did what people often call sensitivity analyses, where they say, do these results hold if we change up the variables a little bit? And I think you can probably take a hint based on how I've talked about some of the methods that this is something I was really excited to see, that for the PNT diagnosis, they restricted only to people for these analyses who had diagnoses made by specialists over a month apart, or with the IC, and then for perinatal depression with the ICD code. Basically what that means is they took out anyone that they used that prescription medication as a proxy for diagnosis. They pulled that out. They said, we don't know if we can totally trust that. That's not like the best way to know if someone meets criteria for a diagnosis. And let's also take away people who have pregnancy complications, because that could be a whole nother layer of stressors that we can't understand yet. And all of their findings hold at pretty much the same degree. So if you remember 2 slides ago, subsequent PND, perinatal depression, was about 5 times more likely in people who had prior premenstrual disorders. These are all like roughly about 5 to me. That's kind of similar. And then same with the other direction as well. So about twice as likely to get premenstrual disorders if you're someone who had an episode of perinatal depression. So this definitely made me a lot more confident in the results, knowing that when they did the most stringent thing, it was pretty similar. So this is me pulling kind of directly from their discussion section, and I'll go through this in one sec. Sorry, I should have animated this slide. I know it's a lot to look at. So their main conclusions for this paper were that there is a bidirectional link between premenstrual disorders and perinatal depression, meaning that if you had one, you have a higher risk for the other, no matter which one you had first. That relationship was more pronounced for postnatal depression than prenatal depression. You'll also hear this described as postpartum depression. So all that means is that people who have a history of postpartum depression were a little bit more likely to develop a premenstrual disorder than those who had earlier depression in their pregnancy. This correlation was stronger among people without a history of psychiatric disorder. And I think there's going to be a lot of people who have a lot of great theories and ways we can talk about why that might be. And then the correlation was stronger in people who have had more than one pregnancy than just one pregnancy. I don't know how to interpret that one, but I do think that was one of their findings. It was pretty consistent. I completely agree with the strengths they have here. A lot of research on perinatal depression focuses on the postpartum period only. So this is a great expansion that it includes people who were diagnosed with depression anytime throughout their pregnancy. And they used prospective data collection, which means that they were tracking these registries that were kept up to date as they happened. They weren't asking people, hey, you have a kid, did you have depression while you were pregnant? And then this is a huge sample size. We cannot shy away from that at all. This is a million. They had a sample of 1.8 million pregnancies. That's phenomenal. And they had great follow-up because honestly, Sweden has great medical records. You'll find a lot of other papers with that. And I'm sure there's people from Europe here. The weaknesses that they acknowledged were that the clinical diagnosis of PMDs isn't a validated metric that they can use and hold up against, they can't prove was valid, and that they can't confirm, and I agree with this one, that the diagnosis or treatment of PMDs were based on prospective ratings, or based on the 2 months of daily ratings that we know is really gold standard for diagnosis. And then they caught a very interesting weakness was that they didn't have the date of menstruation return postpartum. So with that, the reason that's a weakness is that somebody could, in theory, be prescribed a antidepressant maybe 2 months after they gave birth, and they might have put that in the subsequent PMDs group or in the postpartum group, but we don't know if that person was menstruating yet or not. So finally, I wanted to add just a few reflections now, zooming totally out. This is just kind of some thoughts that I had and that I think would hopefully get some discussion going. So I've mentioned the diagnosis weakness, and we talked about it on the last slide, but I think that is a really notable weakness that they did adjust for, but still something worth talking about. I really want to talk about the heterogeneity of these disorders, or the variability in how they present. PMDs, as everyone in this group probably knows, are really different person to person. You can have a PMD without having symptoms of depression. You can be anxious and irritable and have mood swings and other symptoms. So it was interesting to me that they limited the PMD, the perinatal part, to just perinatal depression, when perinatal anxiety exists, perinatal stress disorders exist. There's a lot of other things that might be equal in symptom diversity to PMDs, and PMDs don't have to be very depression forward. So I just wanted to talk about that a little bit. They did very clearly use the umbrella term PMDs to include any degree of severity. So we're unable to kind of know if this is this a stronger link in people who have PMDD versus people who report PMS, or is it the same no matter what, that if you have some menstrual cycle related symptoms, your risk is higher? That's something we don't know. And then I was interested in the follow-up time. So we know that the average time to get a PMDD diagnosis is very long. And it's possible that patients weren't tracked long enough in the follow-up to actually know if they eventually met that diagnosis. This is also true on the flip side. It is possible that some of the people who got diagnosed with PMDD after pregnancy may have had PMDD before pregnancy and may have been searching for a diagnosis or working to find treatment, and it takes a very long time. So there's always that question of timing that we can't fully take out here. And then I do just want to add, it's easy when you're in a journal club to pick apart weaknesses and to critique the study, but I totally agree with everything on the last side, all the author's strengths. I just realized I went about 5 minutes longer than I was supposed to. I apologize, but that brings me to my discussion questions. So I hope that these are things we can talk about in groups together. I think that whether you are a researcher, a clinician, or a patient, we can talk about how this study fits with your current understanding, things you've seen either through the literature, through your day-to-day experience, or in your clinic. Does this article inform any future work for you? Do you think this is going to change your research, change your clinical practice, or if you're a patient, how you might want to approach pregnancy or premenstrual disorders if you're comfortable talking about that? It's always good to talk to us as a group. Anything that I didn't cover that you think are important, something that I missed, something that they missed, an important variable that wasn't considered. And then do you think this article could lead to any changes? Is it ready to be brought for policy or funding changes? Will it change how you approach your patients or what you understand? And maybe not. It's okay if the answer is no. But thank you guys so much for having me.
Great. Thank you, Jordan.
Someone asked what were the other psychiatric disorders. I don't know if I have that on hand. I think so. They definitely had depression, like major depressive disorder as another psychiatric disorder. Sorry, this makes me dizzy when I click really fast through that. Let me just go right to the slide. I think you're talking about, oh my gosh, this slide, right? Yeah, I will check while we're in the breakout rooms, and if I find the answer to that in the methods section, I'll report back when we do our kind of final thoughts.
All right, just for the last 5 minutes, we're going to go through each of the discussion questions. And even if your discussion was, about, you kind of went off on a tangent, no problem at all. Just curious to hear what the different groups spoke about. So maybe I'll start with the first discussion question, and any representatives who feel like their conversation had something to do with that, please speak up. So how does this fit with your understanding of PMDs or your observation in clinical practice or your own lived experience? Or does this article inform your future research or clinical practice or approach to pregnancy?
I can share what we spoke about in our group, if that's helpful to start. We spoke about some anecdotal experiences that we've had with doctors being ill-informed as to what PMDD is, and in the case of both pregnancy related or when people are getting pregnant, and also in terms of contraceptive for people who don't want to be pregnant, and a sort of lack of knowledge and a lack of believing patients, or lack of putting patients first to listen to them when they have concerns, and the kind of problematic issues with power dynamics when you're a patient with a doctor, that often people don't feel able to, or that it can be quite difficult to advocate for yourself when there's that kind of unequal power dynamic happening.
Great, thank you. Okay, the next question is, are there any factors that you feel are important to take into account, or things that were missed in the article, or any changes? What changes can the article lead to in terms of policy or research funding, clinical management, patient understanding? Any final thoughts? And it can be completely unrelated. What did the breakout rooms talk about? what we're
I can
curious about.
share what my group talked about. One of the things that came up of any factors that may have been missed or just things we were curious about that may or may not have been relevant. I know this study started when people were pregnant, but we were curious, what impact of does fertility treatments or IVF play? Like how many people, may have experienced that prior to the start date of the study. So that was of interest to us. We were predominantly patient group, although we did have one clinician present for part of the time. And then we were also just from kind of a sociocultural perspective, just like interested in why they use depression as the marker. And from like, where awareness of the different forms of PMDs and where postpartum depression is. From my perspective, there's less awareness in the US around postpartum anxiety or perinatal anxiety. And so just curiosity around what are the attitudes and social awarenesses of the range of PMDDs or PMDs in Sweden was of curiosity, but not necessarily direct relevance to the study.
No, that's great. Yeah, it's true. I mean, there's so much less awareness of perinatal anxiety relative to depression, and yet it's very highly comorbid with depression, and I believe as prevalent as perinatal depression. And Taryn shared, my group talked about our own areas of interest, such as PMDs and neurodivergence. That's great. Yeah, I mean, glad, this is also a space for people to share the work that they're doing, so. Any final thoughts before we say goodbye?
I was just going to say, I wonder, because the prevalence of trauma and PTSD, medical trauma, birthing trauma, those types of things, that it's slowly becoming more known about, but often undocumented or unrecorded. And I wonder what the interplay is there, if that's sort of a covariate that would be relevant, because I think a lot of women have quite traumatic experiences that people don't treat or don't get access to help after that experience.
Yeah, that's a really good point. So we are coming up on time. Before you head out, we would really appreciate your feedback on how this was for you. This was our first journal club session. So we're always looking to improve and get feedback on, how to make this better for everyone.
Thank you guys so much for running all of this. This was fantastic. And Jordan, oh my God, you make papers that just don't make sense to me, like so clear. So thank you.
Oh my God, that's the best compliment. Thank you so much.
Super appreciated how you taught us to also look at a paper, because I really struggle with what is a credible paper. So just thank you.
If there's one skill you're supposed to get in grad school, it's how to read literature, right? And I think we don't practice enough digesting it and sharing it. So I love doing it, and I'm so glad that worked for you. I'm gonna be on a cloud all day. Thank you.
It was phenomenal. I hope you keep doing this. So just thank you, everyone.
Thanks. Thank you.
We appreciate you and hope you found this session helpful. Please leave your thoughts and questions in the comments below. Stay connected by following us on Instagram at IAPMD Global. Until next time, take care.